Thanks very much, Glenn. So I've been asked to talk to you today about NALHN's experience in implementing patient costing. South Australia has a long history of patient costing, or Casemix as we call it. It started back in the 90s. Now, I've only been around for 15 years, so it's all happened before my time. But I have spoken on my journeys through with a lot of clinicians, academics and consultants that were involved in South Australia in this time, and they always look back with great affection. Clinicians tell me stories about how they used to know their break-even point of average length of stay, their high and their low trim points. They knew how they were travelling on a monthly basis with all their top DRGs. They understood all their ICD-10 codes and how they impacted on funding for their organisation. But along the journey in South Australia, somehow Casemix lost its mojo. Now, I'm not really sure why, but really the challenge for me in my role has to bring back some of that buzz and to get clinicians talking and actively using Casemix and understanding their funding again. So the lessons I've taken from this is this stuff is complicated, and we need to be careful who our custodians are, and we need to train our next generation so we don't lose that momentum again, because it has been quite difficult to bring it back and quite costly. The national funding reform agenda has been the catalyst that South Australia needed to get back on track. South Australia's always had a strong focus on the acute admitted side of their activity, and the national funding reform has assisted us to move beyond that, looking at things like emergency department activity, outpatients, subacute services. It's given us the opportunity to dust off our Casemix staff and even reinvest in some new ones. It's given us a greater level of discipline around patient costing. It's enabled us to improve benchmarking quite considerably. And while this benchmarking is not perfect and still has issues, it is definitely a conversation starter, and I actively encourage my team to pick up the phone when they see anomalies and talk to people in other jurisdictions. And I'm never cease to be surprised at the warm reception that they get when they do this. It's one of the great things about health. We're always happy to share with each other. We've all got challenges, but it's never been easier to connect. Hasn't been without its challenges. For the first time in this current financial year, South Australian Health adopted the acute admitted component of the national funding reform. I had hoped that next financial year they would take this a little further and include outpatients and ED in their funding for the national rules in the state formulas. For those of you that were here yesterday, I think there might be an amoeba in SA Health. This causes us some issues because for people like myself, we're effectively running two models. We're running a state model and we're running a national model. And when we're trying to communicate with clinicians, this can cause a little bit of confusion because we effectively have to train in both models. And whilst benchmarking has improved, it still has its issues. And in the wrong hands, it can be dangerous. Health administrators understand how to read this sort of information, but others don't necessarily. We've had issues with our legacy ICT systems. We've struggled to meet some of the data collection requirements and have had to do a lot of band-aiding and patching to meet the national reporting requirements. Major work in patient costing started about 4 years ago. In South Australia, we had significant inconsistency across the various hospitals. We were all running things quite differently. But in South Australia, we like to do things together now. And together we have implemented PPM, or Power Performance Manager, as our software. We are now costing all metro sites and 6 of our country hospitals. We've approached this a little bit differently to other jurisdictions in that all of the processing of the costing data is done centrally by the central Casemix office. LHNs still have responsibility over their data and their data quality and their feeder files. But by having the processing all done centrally, the idea was to enable us to concentrate on working with our clinicians and concentrate on the quality and the accuracy of the data, and I think this has happened. We have a costing working group that oversee this patient costing system, and there's representatives from each of the LHNs on this working group, and they all work really well together. There's great camaraderie amongst the group. When one LHN finds something that they can do better, the rest of the LHNs are able to quickly pick up and adopt this practice. So I think ultimately, whilst it's had some of its frustrations through this process of implementing patient costing, I think South Australia has ended up with a far higher quality and consistency in its patient costing data. When I started in Narlan, I only had one site that had ever done any patient costing before. It was for acute services only, and it was at bronze standard. I remember having a look at this costing reports that had come out for my hospital, and I could pick faults in it immediately. And I knew that if I had any chance whatsoever in engaging with clinicians, that the quality was going to have to step up quite significantly. I couldn't bear, after 10 years, to have another conversation with clinicians about crap data. So we went right back to basics. I had 2 hospitals that hadn't worked together before, so we had to completely reconstruct the general ledger so that we could have that consistency and made sure that it was all correct for our subspecialties. We went over every assumption and every calculation. I remember walking into the office one day and finding one of my team members crawling around the floor with huge architectural drawings and a ruler and a calculator. And I remember going, really? And she said, you want gold standard costing? This is what you've got to do. Thankfully, we don't have to do that anymore. We have all of our architectural drawings digitally. But I can say that my team have done whatever they physically could do with the systems and the processes that we currently have in place to get the best quality data we could. So in hindsight, we were spot on with the software that we chose. PPM has done everything that we needed it to do and more. The most powerful component has been the ability to cost at patient level. We did all the obvious things and found all the obvious feeder files. We cost at the patient level pathology, imaging, drugs, allied health, interpreters, patient transport, and some others I've probably forgotten. And once we felt that we had a reasonable data set, we started running small work groups with clinicians. And from these work groups, we had really great feedback. In fact, they were quite surprised at the level of sophistication that we'd already got to. And from these workshops, we found all sorts of things that we didn't know existed. We found activity that we didn't know we had. We found services we didn't know we were providing. And we also found data sets that were going to be very useful for patient costing. We set about implementing some of them. Through this journey, we've had to go back and reset some of our costing assumptions. I come from an LHN that has got significant focus on its NEAT performance at the moment, so I wanted to make sure that our ED data was correct. We knew that we had a problem with our mental health patients in the ED. They need a lot of security. They have a lot of specials. They have a lot of patient minding. We have a lot of designated staff for those patients. We wanted to make sure that all the costings assumptions in that space were correct. It's estimated now that through doing this work, that a mental health patient in our ED costs on average about $500 more than a normal patient per episode. From this work that we did with our ED clinicians, we discovered that there was a resus database that they keep on all patients that are resussed. So instead of distributing resus costings across the whole population of the ED, we now do it at the patient level. It was quite surprising to see the results. We'd always assumed that all the resus occurred in Category 1 and Category 2 patients. It's not always the case. We found that there was patients being resussed that were in Category 4 and 5. We also met with our ICU clinicians, and we discovered that they keep a database on medical emergency team attendances, or what we call code blues. We now cost that at the patient level instead of across the whole population. We've got lots of other things which are work in progress. When we met with surgery, we discovered that our stomal therapists keep data at the patient level on their visits. We're looking at doing what we did with code blues to our code blacks. We've just completed, I haven't seen it yet, but I'm told it's completed, is costing on our subacute community teams, and we're starting on our mental health teams shortly. Alone with our mental health, the initial analysis that I have seen shows that we would question how we've distributed our resources within the community's teams. I've spoken to consultants that were struggling to track bad debts and our frequent flyers with bad debts, and their PPM is capable of doing that. I'm particularly keen to progress quality and safety. I think this is a good example of the power of the software that we have chosen. Patient costing doesn't have to necessarily be all about dollars. That if there's a useful KPI or a useful indicator that helps with analytics, we can bring that in. We do keep quality and safety data at the patient level, and the ability to be able to track and potentially calculate the impact of a drug medication error. So definitely something we'll be pursuing. I don't yet have a feeder yet for high-cost consumables and prosthetics, so we're looking at some barcoding solutions in South Australia around that. I can't believe I'm going to admit this as a finance director in a public forum. But traditional finance reports, depending on when you studied, your profit and loss, your operating statement or your statement of financial performance, bore clinicians. They don't find them very useful in telling them or getting them to understand how their business is performing. I've pretended not to notice. I've pretended not to notice the yawns, pages going off and phones going off when they're forced to talk to me about their financial performance. So the truth is that we're running extremely complex businesses, and we need financial reporting that can match that level of complexity. And this new patient costing system is assisting us with doing that. Even I've been surprised at the layers and the angles at which we can cut data. It's endless. This in itself has brought with it quite a lot of reporting challenges. And I know that's been discussed at a lot of the forums here over the last couple of days. We heard from Diane yesterday on the huge variation of hospital performance at the DRG level. We've already been looking at this, and the data she showed didn't surprise me at all. We've been using the patient costing system to drill down and have a look at what the variances in work practices are, and I can tell you it gets more interesting when you actually have a look at the variances on a month-by-month basis. We've noted huge variances depending on what month of the year you get admitted in terms of what your length of stay is. Patient costing is not the be-all and end-all, but it's definitely become a key part of our management toolkit. And I can't imagine what life would be like without it in terms of the demands that we face now for information. From a reporting side of things, I've sort of got three main tools that we're using. SA Health has implemented LARS, which stands for LHN Analytic and Reporting Services. It's a one-stop shop really for reporting. We've also done some of our own customised reporting locally to meet individual needs of clinicians, and we're also active users of Health Roundtable data. This is an example of LARS. Not sure how easy that is to read. The idea of LARS is to provide clinicians with a one-stop shop, so they don't have to go over the place to look for their reports. It can contain things like FTE, data, finance, activity, nursing KPIs, and dear to my heart, ED wait times, and of course patient costing. This is just one example of one of the LARS reports where we can easily now benchmark against our peers. Before you all get worried, you are all de-identified. If we want to know more about who we're benchmarking with, we generally go to the Health Roundtable. Some of our key improvements. In 2013-14, we published our HRT, our patient costing data in the Health Roundtable. This was a major step forward for us because we've never done that before. And what it meant was that our data was of sufficient quality to share it nationally. We're moving now to monthly reporting, speeding up our routines so we can deliver information in a more timely manner. We're continuing to work with clinicians and educate and train, and we're doing loads of benchmarking. It's confirmed for us what we already knew, but enables us to quantify. It tells us what we do well, and it tells us where we have opportunities for further improvement. We actively use it for business cases. In my role as a finance director, one of the things I'm responsible for is the facilitation of savings strategies. And to date, we've had a very input-based focus to financial recovery. We've looked at pathology, we've looked at imaging, we've looked at drugs. We've gone back and reconfigured rosters so we can reduce medical overtime. We've done all those really obvious things. Those strategies are really at end of life now. And moving forward, we definitely need something more sophisticated because the change in the reform that we're going to require moving forward is going to be around patient flow and service redesign. And the patient costing system is definitely assisting us with that. The data has been used for research. We talked earlier about the medical emergency team. There is now research going in, being done at the moment on multiple MET calls and the impact on ICU time, and the data is being used for that. The data has been used to analyse end-of-life strategies, particularly in relation to recent legislation changes. I've also recently been approached to use the data for some research that is going on in antenatal and obstetric care. We've used the patient costing data to really relook at the way we allocate budgets internally. We have a business that is constructed with little mini businesses within, and we get a DRG as a payment, and people like myself need to make sure that we are distributing that DRG payment in an equitable and a fair way. The patient costing systems assisted us to do that. One thing that I didn't expect is through the patient costing system, we've actually discovered suppliers that are overcharging us. I thought we pretty much had our eye on the ball with this stuff, but when you have very, very large organisations, these things aren't always noticeable, particularly when you've got seasonal variances. But by being able to put that activity lens very easily over your financials, we have discovered this overcharging. And my estimation is on the overcharging alone, we've paid for the patient costing system 2 to 3 times over. I often get asked, how do I engage with clinicians? As any way I can. Don't underestimate the informal stuff. I can give ABS lessons in the car park, in the elevator, queuing in the cafeteria. I'll do one-on-ones, I'll do large groups, I'll do small groups. I'll come in early in the morning, I'll stay late at night. Whatever it means in order to really get this information out there. This stuff needs to become part of everyday conversation within LHNs. I'm always really honest. I try to explain the bits of the costing model which are really accurate and highly reliable, and the parts are a bit more subjective and where we've had to do some averaging over populations. We try to really meet the clinicians' needs by providing specialised reports on things that interest them. I always say that no question is too stupid. I want clinicians to feel comfortable that they can ask questions. And we really have noted through the training that we've done, there really is a low understanding out there of what this is all about and all the terminology, and we've really had to go right back to basics. Just some sample reports of some of the things that I've been using to talk to my clinicians. This is an example of an inpatient activity report on carpal tunnels. I think we had 73 occasions at one hospital, but the performance varied quite considerably between the different clinics. So we've been benchmarking ourselves against the metropolitan average in South Australia. So in this particular case, the average is 0.4 of an average length of stay. All clinics are performing below that. But when you look at the average cost, there's considerably different costs at the different clinic levels. So not surprisingly, Clinic B is our orthopaedic group, so tend probably to do the more complex cases. So we would drill down and we would have a look at what's driving the performance in this particular area. It might just be the higher acuity, or it might be a coding issue. I have a bit of a love-hate relationship with my surgeons and my anaesthetists on this one. They love to tell me that my data's not right and these timings aren't reliable, for which I have to remind them it's actually their data. Needless to say, we have been using this as part of a theatre review, and we have been looking at the timings and what a difference 10 minutes makes. So this has been quite interesting, and it will be very interesting over time to see, just by having this focus, a lot of the feedback has been, particularly from the nurses, is they didn't know that we were even using this data and they didn't know what we were using it for. So I think sometimes just by using data you find that you get quality improvement. We've been working with our allied health teams. I'm very lucky I've got an allied health lead who loves data as much as I do. She's really liking the ability to have a look at the DRG level, exactly how many interventions her staff are actually doing. So for an arthroscope at one of my sites, 94% of patients had been seen. At my second site, 86%, and the state average is 39% of patients. So the ability for her to have a look at what patients are being seen when and the potential impact on average length of stay has been really useful, and has enabled her to consider further resource distribution changes. So for an average length of stay for this one, we're below the state average, but the minutes are different. One site we spend less time, one site we spend more, but from an average cost, both sites are below the state average. And the reason that Hospital 2, even though the more minutes, comes in lower is because we have more teaching and junior staff at that site. We're now putting activity lenses over a lot of our diagnostics. This is an example of imaging in our triage 2 categories at each of our hospitals, and again benchmarking at the state average. So state average is 0.8, one hospital is 0.6, the other is 0.9 in terms of average imaging tests. Those costs are fairly consistent. So again, we are using this to have a look at Hospital 2. Hospital 2 happens to be my lower acuity site, but TAS tend to use more diagnostics than the higher acuity site. So as the systems get better, the data will get better, and so will the timeliness. I've heard stories about international hospitals that are able to cost their patients by the time they've left the hospital. This terrifies my staff that I'm going to want this. There's been a lot of talk at this conference about the need to improve performance frameworks and reporting frameworks, and I think we've still got a long way to go in South Australia, but have some good bones. How far can we go? The exciting thing for me would be to have the ability to cost a patient over their entire lifetime. I listened yesterday about some great work that's going on in Queensland in the chronic disease space. The ability to cost an illness, not just an episode of care. So when you've got your finance director at your door who wants to know why you're spending all this money on expensive diagnostics, such as genetic testing, our breast surgeons can now point out exactly what they've saved in terms of oncology services by tailoring treatments to women, so we don't have what we used to have, where often women would undergo varying forms of treatment before we got it right. The ability to cost a bariatric patient over their life and understand what the true impact has been on their health. I've got a father who's about to have his third pacemaker. To be able to have a good time series and how useful this information is going to be in terms of redesigning healthcare and why we think about it. I believe in the North we've created a really good platform to move forward and for future generations to build onto. So whilst I couldn't say that I've brought back the buzz in terms of Casemix, I've had a really good go at it. Thank you for letting me share this journey.